Welcome to Surgeon's Log 2020, Case Archives of the Skull Base and Beyond, a webinar presented by the North American Skull Base Society in association with Global Brain Surgery Initiative. I'm your host, Dr. Walter Jean of George Washington University. If you've enjoyed this and other episodes, don't forget to click the subscribe button on our YouTube channel so that you don't miss any future episodes. For now, put on your learning hats and enjoy this episode of Surgeon's Log 2020. So the presenting surgeon for this episode, it will be Dr. Marc Cohen from the MSKCC and my alma mater, Weill Cornell Medical College. And the discussant will be Danny Prevedello from Ohio State, who needs absolutely no introduction whatsoever. So it's going to be a very multidisciplinary panel. The episode's name is the Sphinx of Gotham. You can figure out why that name is applicable. On the hot seat is Stephen Magill, formerly of UCSF and now Dr. Prevedello's skull-base fellow in neurosurgery at Ohio State. And running the show today, as I said, as I duck behind the screen now, is Dr. Eric Wang, who's Associate Professor of Otolaryngology at UPMC. So without further ado, I turn the podium back over to Eric, who will show the case to Stephen. Go ahead.
All right, Stephen. Well, hope this is a fun and exciting time for all of us. Thank you to Dr. Jean for giving me the opportunity to moderate already what has been a tremendous addition to our educational series. So let's start with the case. As you can see, this is a middle-aged man who presents with a 4-month long-standing history of left-sided nosebleeds, as well as a more recent progression to nasal congestion, but is otherwise asymptomatic, and the social history is significant for travel. On physical examination, it's actually fairly benign. He's acute and oriented. The cranial nerve exam is normal. There's no change in vision. And importantly, there's no adenopathy in the neck. But the endoscopic examination reveals this finding here. All right, Dr. Magill. So based upon this, what are the things that you are thinking about when I know that you may not be performing this endoscopic examination per se, but when these things occur, what sort of things are you considering when you see this sort of presentation? Fairly asymptomatic, except for left-sided nasal symptoms.
Yeah, what worries me is the frequency of the nosebleeds. That doesn't, if I think of, like, if there's a polyp in the nose or something maybe a little more benign that's causing that, that's, you might find some congestion. But the fact that these nosebleeds are persistent for 4 months just seems unusual. And with no other past medical history, no bleeding disorders or other reasons to explain it. And I assume he had normal lab work with normal platelet function and all that sort of thing.
So I don't actually have that information, but I think in this particular setting, that's safe to assume. Is there anything else you want to know about, like, for instance, the remainder of the endoscopic examination? We're showing you a single still picture of a left nasal cavity. On screen left, you see the septum. Screen right, you see the lateral nasal wall and the inferior turbinate. You curious about anything else on the endoscopic examination that's not shown here? Might want to ask your colleague.
Yeah, so I guess going straight to the exam then, one little history question, is he have smell?
So I think that I wasn't given that information, but I would suspect that there is some degree of olfaction. Yeah.
What's the right side look like?
Wonderful question. So the right side is actually quite normal. So does that lean you more towards your differential?
Yeah, so, and he was 50 something, you said, I think?
I think 54 was the title. Mm-hmm.
Yeah, so when I think about something like this, I think about broad categories. This doesn't look infectious. I think this looks neoplastic or some sort of growth. So doesn't look like in a fungal ball or some sort of abscess or anything like that. So I'm immediately moving into kind of the neoplastic category. It's not vascular, so I'm just worried about something growing. The question then, is it a more benign or like a mild nasal polyp or an inverted papilloma? It doesn't really look like a papilloma with the different, it's got different colors on it. It's not smooth. It looks a little bit raw, actually. just to my non-office examining ENT eyes. So those are the types of things I'd be worried about with this type of a lesion.
Absolutely. So what would you do next in your evaluation of this individual?
So based on where the case is at right now, I don't think we have any imaging. You're in the office, and if this is all the way down in the inferior turbinate, I think it'd be pretty easy to take a biopsy of it. We know it's bloody and hemorrhagic, but I mean, if it seems like something you could take a biopsy fairly easily, and it doesn't look to be like a vascular malformation or anything like that that would make me, you know, something that we have to go to the OR. So I think the key is to find out what's going on histologically to guide us. And then after that, we probably, if it's we need some sort of imaging as well, because clearly something's going on. This is not normal. And I don't think proceeding without imaging is a good idea.
Sure. So let's pretend in this scenario that, you know, we'd actually rather just get the imaging. And there are a variety of different arguments people can make for or against doing imaging, you know, more quickly or lateral. But let's look at this CT scan that we're given. Unfortunately, it's a non-contrast enhanced CT scan. So let's say that this gentleman was referred into you. What do you see on the CT that encourages you or makes you worried? What are the things that you're noticing as you look into this?
Yeah, so this is a non-contrast head CT with a bone window, sagittal on the screen left, coronal in the middle, and axial on the right. And the first thing that I see noticeably just starting in the sagittal is there's a large mass. It's filling from the rostrum of the sphenoid all the way almost to the where the hard palate ends, like the border of the teeth, almost to the nasal opening, which is what we would have seen as just the tip of this lesion then. When we look in the coronal plane, we can see it has eroded the bone that's normally where the middle turbinate is, and the lateral and the maxillary sinus wall, and the maxillary sinus is full of something. It could be a trapped mucocele, but I'm going to go with tumor because of the bony erosion that we see there. Looking superiorly in the coronal plane, you can see actually the skull base looks eroded at the cribriform plate, particularly on the patient's left. There may also be extension at the level to the patient's right as well, because that superior ethmoid, it's either superior ethmoid or cribriform, looks like it may be filled, may have some extension there. And then we see similar findings on the axial, looking at the third picture. It looks that it doesn't go deeper than it may invade through the sphenoid os a little bit into the sphenoid sinus, but certainly is involving the ethmoid sinus. And coming back to the coronal, or to the sagittal, the frontal sinus is opacified as well. So there may be some extension in the frontal sinus, and what we see better in the coronal plane, the skull base dehiscence at the cribriform plate, we can also appreciate in the sagittal, I think. That there may be some loss of bone there. So this to me looks like a much more aggressive lesion, eroding bone and invading into the adjacent paranasal sinuses and possibly through the skull base. It looks like it respects the orbital wall from everything that I can see on these images.
Yeah, I think these are fairly representative. So you pointed out the extent of the mass, which seems to be in the olfactory cleft. Would you agree with that, Dr. Magill?
Yeah, it's certainly,
just by the way the axial sort of looks.
Yeah, it looks like it originates there.
Sure. And then the complete opacification of the ipsilateral frontal, I can tell you that's the left side, and the maxillary sinus, those are always question marks on CT. So you mentioned it could be tumor extension. What's the other possibilities that could exist in this scenario?
Yeah, so if you have a mass blocking the outflow of the sinuses, then it could be a mucocele for sure, and just accumulation in there. So I think we need a MRI with and without contrast based on this CT.
Absolutely. So, you know, it could be obstructive phenomena that could be playing into this. Whether that's true mucocele or not, I think it's always a little bit hard to say, but certainly obstruction is quite reasonable. And that's what makes paranasal sinus interpretation with the CT alone perhaps not adequate. So here you have the MRI. Does that help you clarify at least a little bit of what's going on? Now the image has got a little bit reversed. Now the sagittal's on one side and the axial's on the other. But what does this sort of tell you? What additional information does it provide you in comparison to the imaging you looked before?
Yeah, this is a fat-suppressed post-contrast T1 MRI in all three planes. Starting on the left in the axial, we can see that it looks like there's tumor extension into the maxillary sinus, but there's also some black air, or maybe that's fluid. So I think it has eroded the wall of the maxillary sinus and is invading into it, but it's not completely full of tumor. We also see enhancement of the mucosa. There's reactionary phenomenon there. When we look at the coronal plane, it's difficult to see whether it invades the skull base. Clearly, this lesion is involving the ethmoid sinus superiorly, and again, invading the maxillary sinus with obstruction and fluid buildup in the maxillary sinus, but it's not filling it with tumor. What I'm worried about here is how thick the septum is, and it's hard to tell whether it's just displaced or whether the actual septal mucosa bilaterally is invaded and the bone lost. And then in the coronal plane, it looks like the mass is not invading the frontal sinus as much as it is obstructing it. The mucosa looks inflamed, but the consistency of the enhancement of the fluid in there, it's hard to say. It looks a little clearer. I don't know, maybe a T2 would help us there to see whether that's just obstruction of fluid or whether it's actually tumor going all the way to the top of the maxillary sinus. And then as far as the origin of the tumor, clearly there's a lot of enhancement along the skull base, anteriorly in the cribriform and olfactory mucosa, extending back to the anterior portion of the planum. And the CT showed us the orbital wall was intact, so I think that's just in the coronal plane, that's just tumor in the ethmoid. It's not actually invading the orbit.
That's great. That's perfect. You want to comment on the intracranial aspects of this now that we have an MRI compared to a CT?
Yeah, you know, I don't see gross intracranial invasion for this. There's no frank edema. The skull base, I thought, like assuming these are coronal sections are about the same as what we saw in the CT, where the dehiscence was, the enhancement kind of stops within the sinus, within the ethmoid or the nasal cavity right there, where it comes right up to the cribriform plate. And if you can see the symmetry in the cribriform plate. So if there were tumor invading there, I'm cautiously optimistic that it's respecting the dura along there. I'm a little worried that it's extended over into the right side, because if you look there on the side of between the orbit on the right, between the the lateral rectus or the oblique muscle and the cribriform plate, there is some enhancement in that superior side on the right. So I'm actually concerned that the tumor is crossed there.
So you're pointing out right here near this superior oblique here, Dr. Magill, right in this cribriform olfactory groove origin, right?
Yeah.
Am I illustrating the right area that you're referring to?
Yeah, that's exactly what I'm referring to. That it looks like it hasn't invaded the skull base, but it's crossed to the other side there. It's what I would predict based on this imaging.
Outstanding. So you already sort of pointed out what you would like, maybe even before the imaging, which is this idea of what is it, right? So based upon the imaging that you had, and whether you do an in-office biopsy, an operating room biopsy, I think that that's, you know, really probably not the most valuable discussion to have right now. But once a biopsy is performed, what would be that differential? What's going on in your mind? What are the things that you're thinking about right now as you're assessing this individual?
Yeah, so from a overarching like systems, I think this is a neoplastic lesion. It does nothing else. So I think it's some sort of neoplasm. And the question is, what type of neoplasm? When we think about a differential for neoplasms within the nasal cavity, common thing, or there's any sort of high-grade cancer, so sinonasal, SNUCs, SNECs, it's too anterior to be anything from the pituitary gland. I think sarcoma or anything like that is much less likely, but you could. And then of course something that's based on the olfactory mucosa, the olfactory groove, you bring in olfactory neuroblastoma, although that's a relatively rare cancer. And we didn't get any history of smoking or things that might push us towards a SNUCs, but I think it's really the biopsy is going to be the key to show us where it is on that scale.
Absolutely. So, you know, I think, just to interject briefly, I think you did a wonderful differential there, Dr. Magill, but I often tell people to sort of think of epithelial and neuroendocrine tumors in this olfactory cleft. It helps us sort of classify some of the things that we could be considering, you know, because then you can start thinking about the cell types in the area, the potential things that could happen there. This person is an international business person, but let's pretend that this person was a woodworker or was interested in those kinds of things. What would you then consider as a very high in the differential?
A woodworker. So some sort of environmental exposure. You know, nothing jumps to my mind right away that
That's
would be.
okay. So it's actually intestinal type adenocarcinoma. So it's much more common in Europe. It's actually the most common olfactory malignancy. But just to share that sort of thought, we didn't have that in this particular presentation, but I thought it'd be an interesting side note for us to bring forward. So you're already brought us to the next step, which is a biopsy. And here's the initial pathology, this classic answer of a small, round, blue cell tumor. All right. So this is not a test of your overall knowledge base, but based upon this, what are you thinking when you hear that? Let's say you did an and your pathologist says gives you the frozen section of a small, round, blue cell tumor. What are your kind of two big groups, at least for the location that we're looking at?
So esthesioneuroblastoma, olfactory neuroblastoma is a small blue cell tumor.
Absolutely.
I think some of the squamous cell tumors, like the SNOCs, can be small and blue cells too. And then, of course, lymphomas always, when you hear small blue cells, it could be that. Although that in this location, I think that's much less likely than where we typically see lymphoma.
Sure. So actually, that's what we were driving towards. I was actually trying to point out to you the key of, so this is a diagnosis of esthesioneuroblastoma, but you don't want to be fooled with every small round blue cell tumor. Because lymphoma can occur here. I've definitely biopsied it from this location, even though it's, as you say, Dr. Magill, much less common. But it's something we want to think about. You don't necessarily always want to jump to esthesio or other neuroendocrine tumors when you hear that small round blue cell, because obviously the treatment options are quite different for those two disease processes. So now you have a biopsy, so you know what it is. What's the next step? Oh, excuse me. I had one other question. Now that you have the diagnosis of esthesio, would you want any other information from your pathologist?
Yeah, so the key thing here is the Hyams grade, which is a scale basically looking at the histopathological features that go from low grade and more differentiated to more aggressive undifferentiated tumors. I think it's grade 1 to 4. And so that's going to give us an idea about how aggressive it is.
Yeah, we can thank Dr. Cohen for these really great pathology slides. So this one came back as Hyams grade 3. And you can see this loss of the architecture that's classically described with minimal stroma. And then again, these sheets of these small round blue cells. And then here's that high power view showing their little, these high mitotic indexes with early focal necrosis. And then this is like the, the board or the written exam question of the Flexner Wintersteiner rosettes. I'll be honest with you, I've never really looked for one in my entire life. I just asked them to grade it. So what do you think about Hyams grading? What is that? How does that influence you? So here, just for everyone's opportunity to sort of peruse this Hyams grading system if you're not as familiar with it. Dr. Bill, what does that mean to you? So you asked for it, we want to know what it is, but why is that clinically important to you?
Yeah, it gives us, I think it sets expectations and what we need to do. I think what we need to do is staging and workup anyway, but it kind of sets our expectations of how aggressive the disease is that we're dealing with. I think when we think about esthesios, we always think about it, this is a cancer, this is not a benign tumor. It's a slower growing cancer than maybe a SNOC or a full squamous cell like type of tumor, but so a Hyams 3 means it's much more likely that this has spread elsewhere, or that it has the potential to spread and metastasize. And so I think when I see that, that's what makes me a lot more concerned about what we're going to find on the staging workup, and I would start preparing the patient for that, as opposed to saying, hey, I'd be more worried about recurrence and metastasis.
Great. So speaking of that staging workup, what do you want to do for that staging workup?
Yeah, so we need to get a whole body scan to see if it's metastasized. I think you could I think a PET would be I'd probably go ahead and get a PET. I know I actually was just, yeah, so there you go.
Mm-hmm. So, what would be, so in the United States, I think we very commonly use PET CT in this situation. What would be the alternative if let's say PET's not available to you, you're in a different part of the world where PET CT is perhaps a little bit more limited. What would be your secondary option, Dr. Magill?
Yeah, if I had limited resources, I'd get a CT of the neck with and without contrast. I think that's going to show Mets in the neck, which is going to be the most common place we would find them. And that's where I would go. I'm pretty sure. I don't think it's as good as an MRI, and certainly if we're a resource conscious type of situation, that would be my highest yield screening. You could do CT chest and pelvis and look for nodes and
absolutely. Yeah, I think a CT neck and chest is what our Canadian colleagues would largely perform, just because the overall distal metastasis incidence is fairly low outside of pulmonary disease. Any guess as to what percentage of patients present with primary neck disease, Dr. Magill?
With primary neck disease?
Well, with neck disease and concurrent at initial presentation, excuse me.
I think it depends. I think it's like 10 to 20%, and with the higher grades being more in the range of, 15 to 20, 25%, and the lower grades being more around the 10% or less.
Yeah, I think in some multi-institutional trials, it's 15% is the overall neck presentation, with about half of them starting at initial presentation, then half of them developing it in delayed fashion. So that was great. Okay, so I think I messed up the slides, but when we talk about esthesio, the classic staging is called a Kadish staging system. And so how would you stage this tumor, Dr. Magill?
Yeah, so the Kadish stage so it's beyond, if it's just in the nasal cavity, it's an A. This has invaded the paranasal sinuses. It's in the ethmoid and maxillary sinus, so it's a B. And then C is usually if it invades, I think, the orbit or the skull base. And here, I don't really actually see the skull base violated, at least not grossly. And then D would be if it's in the neck, and the PET showed us there were no Mets in the neck. So I think I'd go with a B, and because it's not in the orbit and it's not through the skull base. I'm not sure. I can't remember if maxillary sinus invasion and erosion of that wall would make.
Yeah, I think this one's kind of close on the border between a B and a C, depending on what you think about that particular area of bony erosion and that little bit of lateral lamella that you pointed out earlier, whether that represents skull base involvement or not. So let's kind of quickly go through. So based upon all the workup that you've done, what are the treatment options you would present to this man?
Yeah, so I think the best, so for low Kadish grades without neck metastases, I think it's primarily the first step is treatment followed by radiation. If he had distal neck mets, then we might want to consider induction chemo and certainly get medical oncology on board and see about trying to shrink this down and treat some of it systemically, see if it responds. But for a tumor like his, I think it's surgery number one, and it's, it's always the patient's choice, but it's not like a big, I think we need to do a surgery.
Okay. So what are our goals of treatment in this particular scenario? As you keep mentioning, this is an oncologic problem. So what do we need to accomplish?
Yeah, so the key here is, I think when thinking about these, it's an oncologic issue. So this is not a benign tumor, this is a cancer. So we need to do surgery with margins. We need to get all of this out with clean margins is our primary goal of surgery. We always worry about the functional status as well. And I think, if he has smell on the other side, if it's actually invading across the other side, whether or not we're trying to do this through a unilateral or a bilateral approach and just take it out. But I think the functional status would be what we'd be concerned with. Other things, it didn't look like it invaded the orbit, but I'd often think about the cranial nerves, the optic and oculomotor and abducens trochlear nerve in preserving function there. And then I think age, when we think about that, he's in his 50s, he's got 30 years to live based on the actuarial survival tables. So I consider this a relatively younger patient. Like, we need to get him the best resection we can and then get radiation afterwards.
All right. So again, using this CT and then this MRI, what are these key anatomical things? You mentioned them many times about the orbit. We seem to not have really any significant orbital involvement. Would you agree with that, Dr. Magill?
That's how I would interpret the imaging, yes.
I would do the same. The skull base involvement is a little bit trickier, right? So if we go back to the CT, I agree with you. In general, the bony skull base doesn't look bad, but there are a couple small areas. Where's the cell of origin for esthesioneuroblastoma?
It's in the olfactory filaments, right?
Exactly. So, that's always a tough area to really then judge, and that influences the way we're thinking about this compared to something that's epithelial based, right? Because it really happens at the junction of the skull base. So then, what do we think is the involvement of the bone I think you pointed out very clearly that this doesn't have dural or brain involvement, but there are scenarios where that affects us. And then, as you point out, esthesio is one of those things where the histopathology is more favorable than many of our other considerations. So based upon all that, you're going to operate on this person, or you're going to recommend a surgery for this person. What are you going to recommend for this individual?
Yeah, so because it's not, frankly, invading the brain, and I think the approach is endonasal. I think we can definitely get a good resection endonasally. The difficulties come with considering what we're going to do for reconstruction, and then also whether or not we try to preserve smell and go unilateral. So I think I would recommend an endonasal resection and probably go up on the right side early and take a look to see if the tumor has actually crossed through the septum. And if it has, then you're going to do a bilateral resection.
All right. That was a wonderful job, Dr. Magill. Again, I point out reconstruction here because this is a very tricky scenario, because we don't want to compromise any of these oncologic goals just for reconstructive purposes. So I think that you did a wonderful job on the hot seat. We're going to turn it over to Dr. Cohen now to sort of discuss the case.
Wow, that was amazing. Really an amazing job. I'm super impressed at your answers. You did better than I did when you presented to us. So there's a few things that I think about. I think this is an interesting case, and sort of looking at the way people. Oh, you'll scroll for me, Eric? Is that how we're going to do this?
If you don't mind. Yeah.
Yeah, perfect. So the things that I think about for this tumor type, and this is sort of a moving target in my opinion, meaning how people treated this 5 or 10 years ago is so different than how it would be treated now. This would be a craniofacial resection maybe 10 or 15 years ago versus an endoscopic resection. And in the beginning times, or even a few years ago, there wasn't even a debate of bilateral versus unilateral resection, which we'll see some pictures. What I do find interesting in thinking about these cases and talking about them is that all of these academic centers that we all work at, we present all of these at multidisciplinary tumor conferences, and kind of the moving target or the nuance of who should not get surgery up front. For instance, you can have a patient with orbital invasion, and we had quite a controversial case of an 18-year-old with orbital invasion with a Hyams-4 esthesio that some people were arguing for surgery. We did induction chemotherapy, which can result in a response in greater than 50% of people and 80% of children, and then that influences how you're going to proceed down the road. But for this case where you're not talking about taking out the eye and there's not significant brain invasion and it's not a Hyams-4, it is pretty straightforward in my mind to proceed with a surgical intervention. The point about the contralateral nasal septum is the critical point for my end in the reconstruction for here, where the workhorse would be a nasoseptal flap. But I agree with everything that you said. Surgery up front, as you should do with all of these tumors, an endoscopic resection, and reconstruction depending on the vascularized tissue options is basically sort of where we decided to proceed with that. And it was our impression based on the scans that there was skull base erosion at least, so we were prepared to proceed with a resection of the skull base, obviously, dura and beyond. I think one of the challenging points now, and I've evolved a bit, is sort of which type of patient do you resect dura and olfactory bulb? And I'll show you the pictures in this patient of sort of what we did, which was basically a resection of bilateral cribiform, resection of dura with frozen sections on all the aspects of the dura, and a resection of the ipsilateral olfactory bulb, which somewhat surprisingly had some question of disease in it. What's the next slide, Eric?
So you're talking about the surgical approaches here, and I think you covered that pretty well.
So this is of all the options in terms of ways to approach with the craniofacial resection, incision on the face, and incision from above, which at least here at MSK has been the standard traditional operation. And then the idea with the cranioendoscopic resection, which we do prefer in the setting of a non-viable contralateral nasal septal flap or significant involvement of the skull base and dura. But as I said before, the entirely endoscopic approach, that's basically kind of the considerations. I must admit, we don't have quite the experience of doing the endoscopic approach and the pericranium tunneled as Dr. Wang and his colleagues, but that's certainly an option for someone that doesn't have good vascularized tissue. From our end, we typically would do a lumbar drain, and as I said, the structures to resect, we try to decide preoperatively, but a lot of that depends on what you see intraoperatively. If there's invasion of the cribriform, if there's invasion of the dura, if it's bilateral or unilateral, you can tell endoscopically better than you can tell on imaging sometimes. So this is just sort of for the trainees, just the simple kind of best approach for skull base sinonasal malignancies that involve the skull base. And effectively, if there is invasion of the skin, eye, frontal bone, or maxillary floor of the nasal cavity, or extensive maxillary sinus involvement, or anterior maxillary sinus wall, then that involves a facial approach and facial incision for that sinus malignancy. If there is a invasion of the skull base in that group, then you're talking again about an open craniofacial resection with a facial incision. If there's not skull base involvement, then a transfacial approach is adequate. If there's none of those structures are involved, again, and there's no skull base involvement, endoscopic resection is very feasible for a sinus malignancy. If there is skull base involvement, again, I think kind of a moving target. We tend to be a little bit more aggressive about doing a craniotomy for tumors that extend over the orbit. There are some people that will say that you can do it all from below if the tumor even extends a third of the way over the orbit, and that's a bit much for us. And I have seen amazing videos of significant brain invasion resected endoscopically, and we're a little less comfortable with that here at MSK. So, in this patient, I think it would, with an endoscopic exam of a normal contralateral nasal cavity, we were planning for a endoscopic resection with a reconstruction with a nasoseptal flap. In terms of the key steps for the resection, effectively, we put a lumbar drain in, we biopsied, even though there's no gross disease, and proved that there was no disease in the contralateral nasal septum. We harvested the nasoseptal flap. We debulked the tumor out of the involved structures. There was no real involvement of the medial maxillary sinus wall, but this was all removed. There was no involvement of the lamina on the patient's left or right. And it really, we did a standard cauterization with bipolar of the anterior ethmoid arteries. We did a draft 3, a standard full A8 sinus surgery, did a centripetal dissection, subperiosteal dissection, pushed everything back, and then were able to isolate the tumor at the cribriform. And we wound up doing a bilateral resection. You could see, not great pictures, and I really do sincerely apologize, but you can see our durotomy in that top left picture with the olfactory bulb kind of hanging in the breeze that we resected. And we proceeded then to use Duragen as an underlay, and we put a little bit of sealant on top for good measure, and a nasoseptal flap on top. And I think what's interesting here, this is just standard reconstruction. I think what's interesting here is the frozen section margins are negative on everything, and the frozen section on the olfactory bulb was negative, but there was a question of some disease in the olfactory bulb.
But Mark, you did take dura for sure, right?
Oh yeah.
But was the dura visibly abnormal? Or?
No, it actually was not visibly involved. The cribriform was invaded, and we elected at that point to remove the dura, even though you obviously take the cribriform first, but the dura was not invaded. So, I don't know how, if we would do it differently right now as compared to 2 years ago we did the case, but that's sort of the challenging question, and one of the questions that I kind of defer to Dr. Wang and Dr. Prevedello is, how has your perspectives evolved over time with taking the dura and taking the olfactory bulb in a case like this.
So Dr. Cohen, we're actually very blessed to have two presidents of the North American Skull-Base Society actually on our call right now. So, and not to call them out too much, but we have Dr. Ian Witterick and Dr. Ricardo Carrau, who are both well-accomplished skull-base surgeons who have dealt with many of these particular cases. Maybe we'll turn the question to allow them to give us their input and thoughts, if you guys don't mind.
Of course.
I'll let Rick go first.
Rick, you're up.
Hello there. It's a great presentation. I think that you guys have basically covered the main points of this. Is there as it was mentioned before, this is a subject that is very much in flux. It's a tumor that is rare. Nobody has a big experience with it, and as technology and as surgical techniques have advanced, we have changed the management of the tumor. But I think that the basic concepts you have really touched them very well. And you can see minor differences from one center to the other, but the knowing the biology of the tumor, knowing that it's a tumor that can follow the nerve, so you can have perineural spread. It can be beyond of what you can see both by your eyes and by imaging, and that it requires a full resection. I think that those are the main concepts that are the most accepted nowadays.
Ricardo, would you, in this particular case, would you have done a unilateral or a bilateral resection?
So he said, not sure. So my rules to do a unilateral resection is that number one, the tumor cannot go intracranial into the bulb. If you have invasion of the bulb, there are communications between the two sides. So I cannot do a bilateral. Also, the same phenomenon happens on the septum. So if the septum is invaded, even if you think that it's invaded only on one side, there are communications from one side to the other. So I would do a bilateral resection in those cases. So if the tumor would have been just unilateral, no septal invasion, no invasion of the bulb, I could attempt to do a unilateral resection.
Dr. Witterick, what would you do?
I would follow exactly what Dr. Carrau said. No, yeah. And for Dr. Magill, if you need a job, you know, it was great answers. You did a fantastic job with that. What I would say is that typically I would not favor doing the contralateral nasal septal flap just because you need such a large flap, and I'm always worried that the tumor would transgress through the septum and potentially involve that. So we usually go more with something along the lines of fascia lata, but that's just in the reconstructive era. And when you have a Hymes grade 3, then we would pretty routinely give a radiation therapy. And one of the things in Toronto that our radiation oncologists have tried to use is preoperative radiation, which is highly controversial, but our results for getting negative margins with anesthesia are actually better with the pre-op rads. But again, it opens a whole kettle of fish, and we don't have randomized data on that. And then we wouldn't be doing that on a Hymes 1 or 2, but when it's a 3, then preoperatively we might consider that. And the other thing that you might be getting to is what to do with the neck as well, and whether you would consider radiation therapy for the neck as well, and what parts of the neck, and does that really reduce the subsequent neck disease?
Those are great points. Dr. Cohen, you want to comment on how you decided to treat the neck in this particular scenario?
One of the things that I found interesting in this case is just, you know, thinking about it, there's so many different ways and different arguments for every step of the resection and reconstruction, as well as sort of adjuvant treatment. You know, we were actually surprised that we didn't see gross invasion of the bulb, but there was cancer in the bulb, and we actually looked at it with the pathologist, and we had quote unquote negative margins, but we had microscopic disease at the bulb. So, you know, we were kind of vindicated in retrospect for taking it, where you can make the argument without obvious dural invasion, perhaps that's not really indicated based on some new data. All of our patients that have anything but the smallest of tumors get adjuvant radiation. Here at MSK, we have a robust proton experience, and we do adjuvant protons. If there's negative margins, then the patient would get 60 gray to the skull base. If there's positive margins, they get 66. If it's not a resected patient, it's 70 gray. And then we routinely, based on the literature showing up to 10% or so of nodal metastasis, we'll treat bilateral 1B, 2, 3 and retropharyngeal nodes, which seems a bit aggressive, but to 54 gray, that doesn't seem to be super poorly tolerated. I think that's much better tolerated than the proton effects on the skin, for those of you who see proton patients on the skin and the skull base. And then obviously, you know, the idea of chemotherapy with a negative margin surgery is kind of out the window. But for a high AMS4, it's something certainly to be considered, especially with a close or positive margin. And that's our thought process. I mean, we don't have a ton of data to go on. It's just sort of our sort of reflex to give these folks adjuvant proton radiation.
Well, I was actually going to share a little bit of the data, but since we're running a little bit late, I don't want to cut into Dr. Prevedello's time. So I'll stop sharing my screen and turn this over to him so he can share his experience with us.
Okay. So great discussion, and I appreciate that Rick Carrau is there. So you know, can jump in, Rick, anytime and help me out with some of the any consideration that you want to add here. Some of these slides are yours, so I think that's pretty fair. So I think what I'm going to do is really an overview, like to close the discussion, as Dr. Jean mentioned. And here I'll go through these slides, and I will emphasize what we didn't talk much, and try to go quickly here through things that we already discussed. But the main aspect, I think this is something we touch, very important to have pathology. A lot of these tumors, they look the same on imaging, and there's no like a specific finding that really will tell that is one or the other. You know, typically esthesioneuroblastoma, they have like a formation of cystic bubbles in between the brain and the tumor when you have a Kadish C, but that's not a pathognomonic, it's not on every patient. So it's very important to have pathology. And then you face this issue that we discussed, because even in pathology, if you only look at H&E, most of these tumors, they look the same. It's very difficult to really differentiate. And there's a lot of publications from the past that they actually now think that they actually were mixed, you know, particularly the ones with a very bad outcome, and probably they were talking about SNUCs and so on. So, you know, the immunohistochemistry chemistry got better over the years in order to differentiate all these different blue cells that we are talking here, right? So there's some improvement, but it still is very difficult to separate all these different nuances, even in the pathology. So the message here is that if you see something that look like esthesio, and they're saying something else, it's very important to get second opinion on these tumors on pathology. So it's not infrequent that we get a pathology from outside and we send the slides to our pathologists, or sometimes we feel that whatever our pathologists are saying is not something that we are expecting, and we will send out as well. So particularly like differentiate with SNUCs, because that's a major different treatment, because this will be chemorads as the primary treatment, and you're not going to jump into surgery for the SNUC. So that's very important. I'm not going to spend much time with this aspect, but we talk about the importance of HIMS. I think this was just an overview now, and the Kadish system, and the fact that we're going to put them together to make a decision. So this is what I call the strategy mixed with art, because as you heard in the discussion here, there's a lot of, oh, this is Kadish A or B, and then HIMS, and this is exactly the case. It's interesting. And I think what is fascinating about esthesioneuroblastomas is that there is not a recipe for specifically for every patient. Like you have to really face and understand the disease, understand the pathology, understand the distribution and imaging, and then make your plan. And it's gonna be, there's no right and wrong. So in overall, if there is a tendency for Kadish C and D, which is invasion of the skull base and dissemination systemically, and also a high Hines, that you would then use a more systemic treatment, perhaps even before like surgery. Like if you have Kadish D and Hines 4, we always kind of question, maybe you're dealing even with the SNUC in this situation. So that's, again, you want to revise your pathology, but that's when you will go with more systemic treatment in the beginning. Versus when you're dealing with a Kadish A, B, and a low Hines, you're going to go more for surgery, maybe surgery only even, and a surgery followed by radiation is the most common approach. So this is why I say this, there's a lot of art in esthesioneuroblastoma management, and I think that's what's fascinating. One thing that I want to call attention that we briefly mentioned is the fact that the importance of treating the neck. So if you have high Hines, for instance, and your PET scan shows no neck, no nodules. So I'm going to show some briefly literature that shows the importance of treating this neck, because you may have like a high recurrence and metastatic disease if you leave the neck without treatment, even if you don't have nodules in the beginning. So because the literature shows that up to, it's around 1/4 of the patients going to have a neck recurrence later on, even when you don't have in the initial of the presentation. And higher the Kadish, higher the chance of having a neck recurrence. And the neck recurrence is related to mortality and a bad outcome on this patient. So treating the patient earlier, particularly if you have no nodules in the neck, is something that I think this is part of our strategy. And we recently published our multidisciplinary team here at the Ohio State, the way we treat these patients. We recently published that. The other discussion is about like, I think it is something that we don't hear much anymore, but when I started with the skull base, there was a lot of discussion about like a block resection versus the piecemeal. And what is proved over the years is that if you, like Magill was saying earlier, if you do piecemeal, but you make sure that you get a complete resection of the tumor with microscopic margins, that is actually what is relevant for these patients. Furthermore, the other issues that we have with very large openings is the problem of seeding and spreading disease around, actually more than performing an in-block resection. So this is a patient that I took care of here at Ohio State, or in my, I think, first or second year. This is probably 9 years ago. And this is a patient that 7 years before had a bicoronal with a transfacial approach with what was thought to be a complete resection and block resection of its esthesioneuroblastoma, and came to us with this very lateral like a tumor. And initially I thought maybe something else because patient also got radiation. But when I did a craniotomy, we resect this, and this was esthesioneuroblastoma, recurrent lateral in the orbit. And this was for sure like a seed from that bicoronal approach that implanted in this lateral in this patient. This patient is still alive, like he's like 15, 17 years out from the diagnosis, but he recently actually had a recurrence in the temporal lobe. I actually did a temporal lobectomy on him recently. So he already had like 3 surgeries and multiple treatments, but it's an interesting case showing the issue of seeding disease when the approach has like too broad as well. So a lot of the literature has been showing that the endoscopic approaches, they do very well, equivalent, if not superior, particularly for local regional control of the disease, and also less complications. So overall is being a technique that is proving to be not only less invasive, but more effective for the patients as well, with less side effects. We always talk about the learning curve, you know, the fact that We don't perform any brain retraction. And I always like to emphasize here the two surgeons. I think the beauty of what we're doing here today, we have a multidisciplinary group. Like want to congratulate Dr. Jean for putting this together, because it's beautiful. It's very beautiful. And this is exactly the way we do everything we do in skull base. And the reason we have good results, I think, is because we work as a group. You know, the learning curve it can be difficult, steep, and of course dependent on technology and all these things we know, but is definitely worth. One thing that I like to mention is that we always transferring the pain from the patients to the surgeons. You know, where we're trying to do the whole surgery through two small nostrils, it is sometimes you know, you finish the case and you have your backache and everything, but it's better for the patient, so we keep doing. So this is the corridor that when we talk about aesthesias, this is what we want to have in your exposure, lamina papyracea to lamina papyracea. We often going to remove a lamina papyracea, but very infrequently or almost never we will intentionally open the periorbit, because we believe the periorbit is a barrier for the tumors. If you open it and there's a recurrence, it's going to invade your orbit. So it's very unusual for us to go beyond that. So just quickly here, this was showed like a quick examination of the cavity. Then we always try to understand, like Dr. Magill was saying, like particularly if you're worried or not sure if it invades the other side, the septum, you do inspections at the beginning of the case. We always open the sphenoid. In this case is here demonstrating the removal of the lamina papyracea that we will, you know, to really optimize the resection. And like I said, the periorbit, we tried not to invade. The septum, it's very important because we discussed a little bit here about doing nasoseptal flaps for reconstruction. And of course, this is only possible if the disease is not invading. So what we will do, we would actually start a nasoseptal flap below the level of the tumor, and we will send margins and make sure that the septum is free of disease before we throw the septum for reconstruction. And sometimes you will not have a possibility of a nasoseptal flap for reconstruction, and that's when I'm going to show very quickly other alternatives, particularly like a pericranial flap for reconstruction. And here's like a full inspection. I always trying to see if there's any invasion of disease. This is important. What was already discussed is really to define, can I do an unilateral resection in a Kadish B, for instance, versus should I do a bilateral? So again, it's like Rick mentioned, if the septum is involved or the skull base is involved here at the Ohio State, we will do a bilateral resection. Only if it's really a Kadish A or Kadish B, unilateral in the nose, is that we will try to preserve the turbinate on the contralateral side. And this is important, like we still remove the septum. We don't try to preserve the septum. We really just, the only part of a possible smell that we will preserve is the turbinate on the other side. I think that's like, we're dealing with cancer, so that's very important. So this is a very nice example of the way we would do this. Here you have the two layers in orange here of the septum mucosa, and you see the olfactory bulbs on the top. And if we are doing a unilateral, this is what we will be doing. I'm gonna go back again here. You see the septum, you have the two mucosas of the septum, and both will be resected. So we will be preserving just the turbinate on the other side of the olfactory of the other side. And this is very, very interesting, because what Rick said is very important. When we remove and we resect the tumor all the way to the dura, and we will resect the olfactory bulb and the olfactory tract, if we see disease, even if it's microscopic, we send pieces of that to pathology. And if there's any suspicions of invasion there, we actually abort that decision of doing a unilateral, and we will convert to a bilateral, because we identify disease intracranially, microscopically, then we convert to a bilateral resection. This is an example here, an old picture, but this is an inspection of the olfactory nerve. And here's an example you can see here. Once you open the dura, you see tumor intracranially. And if this is a situation where we are trying to do a unilateral, we will convert this to a bilateral to have an oncological resection of the tumor. We're always sending specimens like margins, not only at the dura, but we also send the olfactory tracts, unilateral or bilateral, depending on the case. So here's just a quick video of a case that we've done not too long ago, just demonstrating how we do this. So we will do a flap like I described. So here's a creation of the flap on the right side. This is a case that we were planning to do a unilateral. So the flap we did on the right side and the resection is on the left side. And it's not easy to perform a unilateral. So it's very frustrating when you spend hours doing a unilateral and then you find disease intracranially, because it's like, wow, it's much easier to do a bilateral resection of the anterior skull base due to the space that you have. And this is a little accelerated here, but you can see that the lamina papyracea is being resected, and then we are all the way to the anterior skull base there. So we're ligating the ethmoidal arteries, anterior and posterior, only on the patient's left side. And here we elevating the septum as well and exposing the dura of the anterior skull base. So here, very important to drill the part of the cribriform. This is again on the left side, and also the part of the crista galli that goes to the left side. And then here we remove the dura, and this is the frontal lobe on the left side only. Here we're dissecting from the frontal polar artery, dissecting down, and you can see the olfactory bulb being retracted. Here we're coagulated in this case and then transected. I try sometimes not to coagulate to make sure they get a good specimen pathology, but it's important you make sure this is the view of a unilateral resection of the skull base. So no tumor visualized. The plan was for a unilateral. We use the collagen matrix intradural, followed then by the nasoseptal flap, and very often we use fat in the sphenoid or in the lower part to help with the reconstruction. So that gives an example of this. This is that case that you just saw the video, and we did a unilateral resection with reconstruction there on the left side.
Danny, one question for clarification: was that a Kadish B or C, or does it not matter?
So this was a Kadish B in our interpretation, because the CT showed the skull base completely preserved, and there was no disease on pre-op imaging or during inspection during surgery on the patient's right side.
But even preoperatively, you had intentions to take the floor of the anterior fossa, take the dura, take the bulb.
Yeah, we always do that. When we say unilateral, we always do that. And that's what I'm saying is not easy. It's not easy. And then if you open that dura and you see tumor, you go like, oh God, like a wasted, could have be home at this point, because the bilateral is much faster. You have much more space. But this is good because Ricky can jump in and tell us, but I believe about 1/3, Rick, of these patients have a normal smell, right? I don't know if you're there. It's not everybody, but we do preserve in a percentage of these patients smell. I think we looked at this not too long ago. Rick, if you're there, feel free to jump in and compliment. Here's an example of a bilateral invasion. So a case like this, you will not even think about. This requires a bilateral approach with a full transcribiform, and that's when we will do a full draft 3 and resect these tumors. This is the post-op with the flap reconstruction. And this is another one that you can see goes bilateral, invades the septum, and you see a little bit of invasion on the patient's left side. So this requires a bilateral as well in our concept. This is an example of a bilateral here. So it's much more space. So then it's easier to understand as well. So here we drill the center, we take it in block, remove the entire bone of the skull base, and then I open the dura laterally around the olfactory epithelium, olfactory bulb as well, and olfactory tract. And then anteriorly, we cut the falx and we try to rotate it in block posteriorly. And this is kind of just an example here. Let me advance a little bit there, but you can see how we use this scissors. Always careful not to touch the brain there. But we basically encounter these two cuts anteriorly where we're gonna have the falx. And always careful with veins in this area. There's usually some veins that drain there. And here's what you see. See, this is the falx, and we use this micro true cut to basically go there. We have to be very careful, make sure there's no artery there. That's the free edge of the falx. And then we rotate the base of the skull completely down, and we cut the dura posteriorly, and then you have the specimen just attached by the olfactory tracts. Then you cut the bilateral olfactory tracts, as you see there, and then we have a full resection of the entire skull base in one piece. And that's what then we start the process of getting margins. We'll send then margins from left and right olfactory tracts, and then multiple margins around the dura here to make sure we got everything. And here's the reconstruction with the collagen matrix, followed by usually a fat graft and a nasoseptal flap. This is something that we've changed recently as well. We've been using reinforcement with fascia lata, particularly after we had I think 2 cases of 10 months later after proton beam having some disasters with necrosis of the anterior skull base. So we start like really reinforcing with more layers in the last couple of years. This is the way it looks like with the flap, with the reconstruction. This is another quick case here just to show the ligation of the ethmoidal arteries and the importance of the draft 3 anteriorly. This is when we take the crista galli down. And here's the lateral exposure. Very important to get that dura exposed very laterally there. This is that cut on the dura, exposing the brain as lateral as possible. And sometimes we see this invasion in the brain and more aggressive tumors. And but here's the detail of cutting the olfactory tracts bilaterally, and then sending the specimen to pathology, and then we'll send the final reconstruction there, and we'll send the margins as well. So here's that video. So this is the typical bubbles that I mentioned that you see on top of the esthesioneuroblastoma. That's kind of considered one of the pathognomonic like signs of esthesioneuroblastoma. This was esthesion, an older man, and we resect this completely endonasal, and he did well actually until the last follow-up, like 5 years later. He was doing great. This is another example with intracranial extension that we do the resections mainly endonasal, but like I said, if we have invasion of the septum going down, that we would use a bicoronal incision, but really like just to get the pericranial flap for reconstruction. And that's the video here, another case where we resect the anterior skull base. And this is an interesting case that we were testing, if I remember correctly, we're testing a laser, and we actually used the laser like right there to cut the olfactory tract and the dura in the back. But I don't recommend, I don't like much. I feel that it goes beyond the tissue. It's easier to just pass the scissors there, but we're trying to see there with the laser. I wouldn't do that anymore. But that's what we did in that case. And I think also probably damaged a little bit of the specimen for pathology there, but that's what we did in that specific case. So the concern of leakages is always there. I think we're getting better and better with that reconstruction. Like I said, we've been reinforcing with fascia lata for this complete anterior skull base exposures. Sometimes, you can use a lateral wall for reconstruction as well, but because the disease is in the nose, if it is really compromising the septum, the lateral skull base wall, it works, but we use primarily the pericranium for reconstruction when you don't have a nasoseptal flap available. But a lateral wall is something that always a possibility. The temporal parietal flap is a flap that we also use, but we use more for the clivus. For the anterior skull base, we prefer a pericranial flap that we passes through a small opening at the nasium area below the glabella. You put a access directly to the frontal sinus, and then we can move the flap to cover the skull base. Not always is going to be endonasal. This is an example when it goes very anterior superior here. There's no reason for us to suffer and try to resect all the way there. That's going to be, this is a case that we would augment with a craniotomy. This is another one that we would, this is a snuck, but if it was anesthesia, like if it goes very anterior, we discussed about this earlier. This is an example of a situation we will do a craniotomy. So these are, I'm not going to go too much over this, but this is the way we're going to look at the outcomes as well, based on Kadish, based on the Hines, and the TNM classification as well. And this showing that this is an older series when we looked at the 3 patients that were not that they actually died of the disease. So it can be variable, like you can have high Hames in these 2 cases, but one of our patients actually died of the disease that started with a Hames 1, but he had a Kadish C. So that's why you really have to work with both components of the classification. And this is the series that we recently published with 39 patients treated at Ohio State. And I hear the main message that I want to pass is the importance of radiation to the neck for local control. I think that's what we learned by looking at our own numbers. And I think that's what I want to emphasize. As you can see here, patients that got radiation only in the primary area, they actually had worse survival than the ones that actually had radiation to the local primary tumor and also in the neck as well. So I want to finalize saying that once again, the beauty of all this is really to have a team. And I don't think we can treat esthesioneuroblastoma without a multidisciplinary approach with neurosurgeons, otolaryngologists. Very often we have ophthalmology because, there are some cases we have, unfortunately, to do orbital exenteration that we didn't talk much here, but if it is invading the orbit, that will be the way that we will perform. Thank God most of the anesthesias don't invade the orbit. And having radiology, neuroradiology, radiation oncology, everybody, like even endocrinology after radiation. So it's very important to have our full team taking care of our patients. So with this, would like to thank again Dr. Jean for the invitation and for this beautiful seminar webinar that we had today.
Well, Danny, before you leave the podium, I have one question for clarification yet again. In one of Mark's slides, there was a tree that said, decision tree that says transfacial, craniofacial, cranial endoscopic, and so on. But it sounds like from your discussion that you don't see a role of ever opening the skull anymore.
No, I did.
Is that correct?
So I showed very quickly the ones that we would do a craniotomy or even a transfacial. I can even share very quickly here.
Okay, so I'm sorry, I missed that part.
Yeah, so here, can you see there? Yeah, see, this is an example of a patient that we would do a craniotomy.
Okay.
See there? It's invading more anteriorly. I was trying to go quickly, so I apologize, but this is an area that's what I meant. It would not make sense for us to try to remove this endonasal, right? Okay. So this will combine with that transbasal, like taking the frontal bar, or not necessarily the frontal bar, but definitely enter the frontal sinus and exenterating the frontal sinus and removing the posterior wall of the frontal sinus and attacking the tumor with a craniotomy. So we do have some examples that we will actually add a craniotomy, but we'll still do an endonasal on this. Actually, for a case like this, Ricky will start endonasal. He will clean the endonasal part first, and then we will open the bicoronal, elevate the pericranial flap, and then we will do a craniotomy and get the tumor from the top. And then at the end, we're looking to each other through the hole there, and then we will do the reconstruction together.
So there is still a role of craniotomy, but there's no more transfacial and craniofacials.
Well, I had one case, I think it was not anesthesia, but sometimes anesthesia will be rare, but there's some other sinonasal malignancies that may actually invade the skin very anteriorly here. Yes. So we will do We'll do sometimes remove orbital exenteration, work it through the orbit, is really like what the tumor is doing, but if affects the skin very anteriorly near the caruncula here in the eye, for instance, then we would actually open the skin there and possibly even resect part of that skin. So if you're resecting part of the skin, then that doesn't make sense to try to do endonasal only. And we would actually do a Ferguson type of approach and go through there. But for aesthesios, it's less likely, it's less common. Most likely, most of the time, we actually perform endonasal only.
Eric, would you agree with the Pittsburgh experience as well? And I also turn it back to you.
Yeah, I mean, I think that that's very true. There are times we do a small craniotomy through the frontal sinus, especially a well-pneumatized frontal sinus for disease, as Dr. Prevedello has demonstrated. Again, I think for aesthesio, it is quite rare. I mean, we will combine it with transorbital approaches from time to time, and I think that that is still a frontier that we're still all trying to understand and balance the need for all of those things. But, you know, we're already 10 minutes past our allotted hour. I'd really like to thank Dr. Cohen, Dr. Magill, in addition to Dr. Prevedello, and then our guest appearances from Dr. Witterick and Dr. Carrau. And of course, thank Dr. Jean and Dr. Wang for their continuous support of this Surgeon's Log. I think this is a wonderful avenue for which we can learn from each other in a very easy to digest format. As a last plug, this is also co-sponsored by the North American Skull-Base Society. This is one of the tremendous benefits of being part of that society is these sort of multidisciplinary, multi-specialty interactions and discussions, learning from each other's point of views. And I think that this is really one of the strengths of the North American Skull-Base Society. So for any of you who are not members or interested in joining, I think this is a wonderful venue to consider doing that. Even as we are virtual this year, you can still see that there is a lot of benefit to it. So I'm sorry, I think there is one question. Do we need to answer this?
Yeah, let's answer that. That's a good question.
So the question is that about precautions you take to avoid post-surgical seeding. Dr. Cohen, you want to take a first shot at that?
I would call Dr. Carrau and ask him what he does. No, that's a great question. I don't think that I don't have a good answer. I mean, I try to hold the basic tenets of oncologic surgery, and obviously it's challenging when you're not talking about an end block excision with a craniofacial resection. Try to remove all the tumor, irrigate as much as possible. I don't have a great answer for that in head and neck oncology at all, or skull-based surgery. I don't know.
Yeah, so we do use some protective. So Mark, we use some protective sleeves that are designed for endonasal, and I think that those things, I think they have actually quite a bit of benefit in something like chordoma, where we expose a flap and it's a bony tumor, and so the bony floor is quite possible to be seeded. I have actually not seen a seeded aesthesio in the nasal cavity. I don't know if Dr. Witterick or Carrau has seen that. I haven't. Have you seen that, Dr. Cohen? Yeah, so I think that maybe for aesthesio it's a little bit less. But if you think about protective things, devices into the nasal cavity to sort of minimize the mucosal injury, I think the intact mucosa is actually probably a very good barrier for many of those kinds of things. The second question is, do you use a dural patch to close the dural deficit? So I actually tend to use a 3-layered reconstruction for this. I tend to use a collagen inlay, as has been demonstrated by both of the very nice videos and pictures shown. I almost always use a fascial allograft as a secondary barrier. I tend to place it in the epidural space, so between the bony skull base and the dura, and then whatever vascularized reconstruction happens to be available. Especially, so this follow-up question is, how do you reconstruct this?
That thing that keeps you higher. The booster, yeah? Okay, I will get the booster for you.
I don't think that they're answering the question, although my Spanish is Danny, as you were mentioning that you have been increasingly using fascial lata, do you think that is very beneficial, especially when you have, let's say you do a supramedull orbitotomy, or you take more of the medial orbital root in the lamina propria?
Yeah, And the interesting, the key is we do exactly like you said. Like we use, we may use actually 2 layers, one inlay and another one epidurally on top of the orbit. And that one epidurally on top of the orbit, you want to dissect and create that plane before you open the dura, because after you open the dura, if you try to create that plane, the dura just kind of
it's very difficult, isn't it?
really, yeah, that's right. And that's a trick that we learned with Dr. Castelnuovo. We were in Milano there with him and Varese, and we saw him doing that. It was beautiful. And that's actually when we start doing it. So we put a Duragen or collagen matrix first, and then we put a 1 layer of fascia lata inlay, then followed by one in the epidural, supported by the orbits laterally, followed by a nasoseptal flap, and possibly even fat graft in the sphenoid. So it's an intense reconstruction. And just to go back to what we do for avoiding seeding, I think that the video that I showed hopefully showed more or less, but the idea is that once we finish all the debulking of the tumor of the sinonasal area, we irrigate very well before opening the dura. And when we open the dura, I try not to touch the tumor much. And then we go around it, like I showed, opening the dura, cutting the fox, rotating everything down. And we feel that way we're not kind of spilling much of that intracranially, which I think is one of the main concerns, having seeding intracranially afterwards. So that's what we try to do, but it's a microscopic disease. I think it's not an easy task.
Well, with that, I think, you know, we're a little bit over the hour, and I think we'll have to let all the panelists go. My great thanks for Eric for running the show so well. Stephen, you did better than I did. I would have done. I would have just flubbed all that, and you did a much amazing job with being on the hot seat. Danny and Mark, thank you for your presentations and your work. I do have one plug. In addition to membership signing on to NASBS. We are back in two weeks with yet another episode of Surgeon's Log 2020. This time the guests will be Eric, will be Ed Vates and Juan Fernandez Miranda. So we are staying in the anterior space, shall we say, and we're going to talk a little bit about pituitary surgery in depth. So with that, remind all of you to get your friends to watch this episode on YouTube. It will be on probably tomorrow. And once again, thank you all the panelists. And by the way, thank you for the royalty of NASBS for joining us today, both presidents, past presidents. And I believe that Carl Sineman was on briefly as well. So good night, everybody. Thank you for joining, and see you in 2 weeks.